Greetings, everybody. Welcome. We start in a few minutes. And background. People have a tendency to come later and later. Here's the speaker, Luis from Spain.
No es un panelista.
Hey, buenos días, Luis. Ah, Takashi.
Sí.
Oh, hola, Luis. ¿Está bien?
Perfecto. Perfect.
Ok, tú conoces, tú eres un experto, tú conoces cómo compartir, ¿verdad?
Sí, ahora tengo aquí mi hija. Me ayuda.
¿Quiere probar algo, un video, algo?
El vídeo no, solo imágenes. ¿Dónde pongo las imágenes? Compartir.
No hay problema. Ok, Takashi, buenos días. Hi,
Buenos
Takashi.
días. Buenas noches, buenos días.
Hi, Akira.
Hi, Kashi, yeah.
Es Luis de España.
And my friend.
España. So,
Hey.
yo soy, mucho gusto. Yo soy Takashi con Japón,
Yeah.
Tokio, Japón. Mucho gusto.
You speak Spanish very well.
Sí,
Gracias.
sí, él viene a muchos charlas,
Sí.
Luis.
Esto pongo aquí.
Pero, Takashi, con Luis yo fui a España. Yo fui a España para televisar su congreso. Muy buen viaje.
Muy buen viaje, okay.
Sí, we televised Ben from Spain because he couldn't get to Spain because of some travel
No,
problem.
avísame, te lo pongo.
¿Esto qué es?
So we were able to televise him
No,
from
dale a
China.
Para que se te ponga en inglés, pero pasa.
And that's when I first
No te
met
oigo.
Ben.
Cancelar,
¿Por qué?
porque sí. Bueno, ahí está. ¿Te tiene algo, vale?
No.
No, vale. Bueno, cualquier cosa avísame.
¿Cuándo empiezo? Espera.
Tú tienes asistente, ¿huh, Luis?
Sí. Tengo asistente como tú.
Okay, vamos a encontrarla.
Es mi hija, la pequeña.
Okay, vamos a encontrar.
Hello.
Hola,
Hello.
no puedo ver. Oh,
Qué
remove pen,
monos.
okay. Oh, okay. How you doing? Thank you very much,
¿Qué dices?
Lucía.
Lucia.
Se van conectando.
Luis, yo quiero ir a Madrid.
Ok.
Haga un congreso.
Ya.
¿Cómo está su nuevo hospital? Está ya un año, ¿verdad? Más que un año.
No, empiezo ahora.
Oh, okay.
Ahí empiezo ahora en verano, en julio.
Okay. Oh, okay. ¿Vas a televisar mucho de allá?
Sí. Gracias
Ok, yo voy a trabajar allá.
Qué
Vámonos.
monos.
Venga.
Vamos a hablar más tarde sobre esto, pero estoy serio.
Perfecto.
Un parte del año yo quiero vivir en Madrid. Un parte del año y otra parte en Miami. Nunca puedo salir de Miami.
¿Te gusta?
Miami es como Madrid, está en su sangre.
Eso.
No puedo salir tanto tiempo.
Pues tú me dices cuando empezamos.
Okay. Takashi is the same feeling. He wants to travel the world
Yes.
to various neurosurgery communities. Right,
Yes.
Takashi?
Yeah, I try to travel around the world, neurosurgical travel, so to watch several institutes worldwide. Yes, so that's my dream. So I want to contact many neurosurgeons around the world, and the differences sometimes we call standardized neurosurgical and international gap. We have to uh, lessen the international gaps of neurosurgical nuances. Yes, that's my dream.
Perfecto. Aquí tú me has silenciado, ¿no?
Sí, si queréis silenciarte aquí para silenciarte. ¿Me pone audio?
No. Déjame chequear con Juan Lee. Espera. Trying to get a hold of Juan Lee now. Thank goodness I have WeChat. Yeah, hold on, Luis.
Hello, team.
Hello. Good day. Godfrey.
Yes, Godfrey.
Hi, you want to introduce yourself?
Yes, I'm Godfrey Basara from Congo.
Welcome. Welcome.
Thank you so much.
Okay, well, Luis, we'll start, okay? And Juan Lee or Ben will come in as we go along, okay?
It's okay. It's okay, sir. Thank you.
Okay, here, Luis, ¿you're listo? Luis?
Yes.
Okay, 10, 9, 7, 6, 5, 4, 3, 2, 1. Good morning, this is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today is the China Neurosurgical Journal Bimonthly Webcast. Today we have the honor of having Spanish interventional radiologist from Madrid, which
Lucía,
we televised Louis from there at a conference with Ben previously. And I'll turn the floor over now to Louis. Welcome, Louis. It's all yours.
just a minute.
Okay.
Lucía. Few seconds. A ver, ¿cómo hago? ¿Compartir? ¿Es esta?
Y ahora compartiendo pantalla.
Esta es la última.
No, es la primera. Las vas pasando por aquí.
Es la última. Estás al revés.
Vale, a ver.
Ok,
Ok, bueno.
I am ready.
Ok, listo.
Con esto le cambio también, ¿no?
A ver. No, tiene que ser aquí. Mueve el ratón. Tiene que ser pinchando aquí, ¿vale?
No, sí, con este ratón va.
Ah, vale, pues ya está, perfecto. Luego,
Ok, first
compartir aquí eso.
First of all, is homage to my friend Professor Juha Karnezniemi. He come to Madrid many times in a course, Neuro International Master Course. Is nominated academic of Ciencias de la Salud de Ramón y Cajal. And introduced me to Professor Bin Shu, a professor from China. He's a good friend. This is my team in Hospital de San Carlos in Madrid. And today I want to talk the spinal AVM, classification and endovascular treatment. I don't work more in the hospital Clínico de Madrid. I start in few months in another hospital. I learned in France, in Hospital Bicêtre, the 81 to 86 with Pierre Lajunias in Bicêtre. I studied the angio-architecture of the brain AVM. One propulsion chamber is method to embolize, pulsil marco catheter, management of the glue, vein of Galen fistula, proliferative angiopathy, special malformation, and spinal AVM with Professor Michel Hurt. This professor worked with René Jinjian in Hospital Lariboisière. Is the first neurointerventional describes the angiography medullaire and embolization of the AVM, medullary and external carotid artery. In this period, 81-86, I have a competition with the Hospital Bicêtre and Hospital Lariboisière in the method of embolize the spinal AVM. In Lariboisière, Professor Merlan described the same anatomy, but the embol is utilized in Lariboisière is the particles, it's polyvinyl alcohol. But in Bicêtre, La Junias, and me, I am the first pupil of La Junias. I describe and embolize the spinal AVM with glue. It's most difficult, most dangerous, but most definitive to cure the AVM. Now, every case is possible to treat with this. Sometimes I need to utilize the particles. Today, everybody utilizes the glue, but in 81, 86, only Bicêtre. This is Pierre Lajunias with one image to the fistula, intracranial fistula. The anatomy, the most schematic for understand is these three pictures. The spinal artery, you are anterior spinal artery, is Adankiewicz in dorsolumbar region. This is anterior and posterior. The posterior and anterior, you have the anastomosis, PL arterial plexus. This is very important. It's the same of the brain. You are the anastomosis of the anterior and posterior. This is the radiculomedullary. This is the anterior. And this is the plexus anastomosis with the posterior. The posterior, the level of posterior sometimes, every time, it's possible different to the anterior. But you have the anastomosis, circumferential anastomosis, PL plexus, and you are the straight arteries going to the posterior asta, anterior asta, and this is the sulcal artery. The sulcal artery is from the anterior spinal artery, is of the anterior part of the medulla. And the posterior, you are the short sulcal, is for the posterior. This is the most important. To recognize this branch, and this is anterior. In angiography, you are anterior spinal artery in this part, posterior spinal artery in this part, and special disposition of la sorte is an anastomotic or basket in the conus, and you have many anastomosis. This is very good solution, but you are the flow going very well to anterior or posterior, with the perimedullary. For example, this is Adamkiewicz anterior in AP view, lateral view. This is a small anterior branch of the Adamkiewicz, this part. This is the radicular intercostal artery, and your anastomosis to the bone, and your anastomosis to the another part, posterior part to the another side. But the important is the origin of the Adamkiewicz or interspinal is this part. And you need every time to know the localization. And as you see here, you are the spinal, and this part you have anastomosis circumferential, and this is posterior, and this is posterior. The same of Lathortes. This is only posterior spinal artery. The difference to recognize this is the middle part of the canal is here, and the posterior branch, spinal posterior, is more lateral, is not in the medial part. But this anastomosis in the spinal cord is not only of the intercostal branch, it's also with the intraspinal anterior communication. Sometimes in the cervical, much of the time in the cervical region, the spinal artery is double. Why? Because it's the more important region, and you have possibility to treat more lesion or rescue more tissue. But the most important is this. The concept is also you are the superior inferior anastomosis with, for example, from this. The spinal anterior, you are the anastomosis up. Continue to the cervical region. Also, you are the dural artery. This is a preparation, anatomical preparation. With Professor Lathorte, you are the meningeal arteries. And this is the origin of the dural fistula. This is the meningeal artery, no venous, meningeal. And it's very interesting because it's the origin of the most common malformation of the spinal cord. One simple classification is you are paravertebral and muscular malformation, bone hemangiomas, this don't talk in this topic, extradural malformation, dural AV fistula with perimedular anastomosis. This is the most frequent pathology. Fistulas perimedular. This is perimedular, it's intradural. This is extradural. This is intradural. And pial or intramedular. In resume, you are the perimedular fistula, the most frequent, with these arteries, meningeal branch. Perimedular and intramedular. A metameric Cobb syndrome, you are muscular, bone, and this associated malformation. In this metameric Cobb syndrome, I present some case. Dural fistula is 60% the malformation of the spinal. It's the most frequent. In this schematic, you are the arteries, meningeal arteries in this point. You are venous, some small branch, going to the wall of the dura, and then drain to the vein. This is arteria, is open the dura. This is imagine is inside the dura. This is the vein, and this is the point going the anastomosis to create the fistula. The symptom of this fistula is a myelopathy due secondary of venous hypertension. The clinical is progressive deficit motor going to the paraplegia, impotence, and loss sphincter. One characteristic of this dural fistula in generally no bleeding, no produce hematomyelia. Is not frequent present subarachnoidal hemorrhagic. Only the diagnosis is for the hypertension, the venous hypertension, and this created the deficit. This is one example with MR. You are the vein. In AP view, the vein, hypertrophy of the vein. And one thing is the hypersignal in the conus. This is edema. This is edema secondary hypertension, venous hypertension. Chronic ischemia to the venous hypertension. Before the period of the MR, when I work in Paris, the diagnosis is only with angiography or myelography. And in the years 50, Professor Alagionin in La Salpêtrière described this fistula, operated fistula, the neurosurgeon removed the vein, and the patient have a definitive paraplegia. This is the reason to be careful to embolize these fistulas. You need to know 2 points. 1 point is essential to identify the origin of the anterior spinal artery is the same origin to the fistula. this situation is not good to embolize. It's not easy surgery. To treatment by surgery, this is easy. It's only to put the clip in this part, in the vein, no in the artery, because you are possible risk to close the Adamkiewicz. Why you recognize the artery and the vein? I back in second, 1 second. When you stay in surgery room, you open the dura, you localize with a clip the feeder extradural, and then you open the dura and you clip in this point. And you close the fistula and don't touch the spinal artery. This is the method to operate the dural fistula. This is another example. And this is the second point when you are be careful. Be careful when I treat it by endovascular approach. See, you know, the flow is very slow. This is the catheter in the pedicle. This is the meningeal branch. And when you localize the change of caliber of the vein is larger and the feeder is short. This is the meningeal. Your embol only is important, is not going more distal part from this. This is possible. It's not, you don't need to embolize every vein, because you embolize every vein, you are restricted flow in the vein and secondary progressive thrombosis of the vein, and you are also paraplegia. You see, this is the embol, MCA. This is the glue, the pedicule. You are the glue in the vein, in the origin of the vein, but not going more far. This is post-embolization to cure. Is the second point. This is a cervical localization. I have also the fistula of tentorium draining in the cervical region. But this is in T1, T2, T3. Where is the origin? This is the meningeal branch. They change the caliber here. And this is the fistula. So you don't have the selectivity of this branch, you don't see the fistula. You need to know that. One, you put the microcatheter. Look this, you are the meningeal branch, and here you are a slow flow to the fistula. Let's say, you put the glue diluted, dilution in this case about 8 times of lipiodol to 1 portion of MCA, and you close the fistula. The second type is the perimedular fistula. You are the short caliber, the long, or giant. I put some example. This is a perimedular fistula. The imaging is mimicking the dural fistula, but it's not the dural fistula. You are the same, you are the hypersignal ischemia on the conus, and you are this and this. Do you know what this is? This is vein, but this is artery. It's more straight. Look, this is the pedicle going to the artery, this artery descending, tortuosus going to the conus, and then up to the vein. Look that. In lateral view, you are the artery, arteriospinal, going, anastomosis, aortic anastomosis, and vein. This lesion is most easy treated by surgery because it's very difficult to navigate with a microcatheter to this point. And you are the risk reflux, the onyx here. It's most easy localize this point, you open, and you distinguish the artery and the vein. Simple surgical approach. After surgery, look, spinal artery up. Post-surgery, after surgery. This is another example. Another example is the short communication with the feeder and the fistula and the vein. We are also hypersignaling the conus. You are the venous approach, the venous, and this is the fistula. You are the artery, radicular artery, fistula. This is posterior, spinal posterior. A second posterior spinal artery in another level with the perimedular and the vein. This is the fistula, short communication, and drainage. Look, that is very long drainage. Embolization with the glue. With the glue, and this is the control after embolization, spinal, anterior spinal artery, before and after. Before, posterior, anterior, after. This is an 8 months young lady, or no, boy, with hematomyelia. They put the microcatheter in this feeder and inject the glue. The glue going to the pouch. Also the glue reflux in another pedicle, only with one injection in this point, inject the fistula, and two pedicles, this is the control after embolization. And now the third is embolization of the rupture cervical spinal AVM in cervical region. The first case is 20-year-old intramedular hematoma, paresia left arm. You are the vein, MR, you are the hematoma. In this point, is white. You are the edema. Sagittal view. You are the ascending drainage to the posterior fossa. And this is the left vertebral artery and right vertebral artery. Nidus, vein, nidus, vein. And you have many branches. Is anterior or is posterior? This is posterior, this is anterior. This is anterior. Spinal anterior. And when you work, you need two catheters. The catheter one is to check the malformation. The catheter two is to check the anastomosis with the spinal artery. This is lateral view. You are anterior, and then is posterior. Selective injection of the nidus and progressive embolization with glue. This is final control, totally occluded. I have 5 years after embolization, 6 months, and 5 years after embolization. You see all anterior spinal artery, some reliquant nidus, but occluded in malformation. 12 months, total disappear. Another 27-year-old intramedular hematoma. This patient is treated before myself with another center and closed many years ago, closed the anterior spinal artery. And no, it's not, no. No, this patient is not this. This patient is treated in Colombia. Sorry, in Colombia. You are a pouch, you are a nidus, anterior anastomosis, and this is posterior. This is a venous pouch. I inject with my catheter to go to this point. And inject the glue, and this is the control in the left side. In the glue, totally occluded with the left branch. Look, but the second embolization is in the right vertebra. This is the remnant in the right. The problem is treated before and don't have the possibility. You are here a small dissection, and the risk from this is you are anterior spinal artery. I need to place the catheter in this point and inject the glue, but not reflux. This is the pouch, this is the dissection, this is anterior. This is anastomosis with the spinal, anterior spinal. And I inject selective here. You are the anastomosis of the anterior spinal. You are here, the AVN. But inject the glue and don't touch the spinal artery. and close the AVM. Look this. In the left side. This is another patient, also 27-year-old, Takotsubo syndrome, after choreography of hematomyelia with edema, hypersignal hematoma. Now you are one, anterior spinal. This is the dorsal branch, upper dorsal branch. This is the ius. This is the vein. Look, the vein, anterior. After embolization, totally occluded the malformation, as this is the glue, in the medulla. 20, this is the patient I talked before, 22-year-old. This patient is treated 5-year-old with another center, partially treated the AVM, but it closed the anterior spinal artery. This is the magnetic resonance, complex AVM, hypersignaling cervical region, cavity of hematoma, and in AP view, you are this AVM and this branch. This branch is this. What is this? Is anterior or posterior? The problem is that the anterior spinal artery is here. But this portion to this portion is occluded, going by another way. And the injection of the AVM is with posterior branch. You are here one perimedullary artery posterior, and you go here. Branch, perimedullary artery, and go. I study selectivity, and you are here. Perimedullary, I'm going final to the perimedullary artery. This is arterial. You going to here. Look, very difficult, but you are the nails navigated by perimedullar artery. This is the control. You are the remanent, but you are the spinal artery, anterior spinal artery, and posterior, and the glue. Finally, this is the Cobb syndrome. This is cervical dorsal AVM metameric malformation. You are the skin, you are the bone, you are the nervous system, and this is the complex AVM, very long, the AVM and the drainage and the vein. And you are many feeders with ascending, with the right vertebral, with T2, T3. T4, T5, look this. And this is the bone malformation. This case is impossible to treat with glue. This is the reason this case is treated by particles, high value. Don't cure the AVM, but decrease the flow in the AVM, and the patient improve or stabilization of the symptom. Look, this is the vein. This is multiple pedicles injected with particles. Post-embolization. You have partial desvascularization of the AVM, and stop here. And this, look, this is the funnel. Logical, after few months or a few years, this is recanalization because it's a particle. To conclude this part, the dorsal lumbar localization is delicate region to treat because you are sphincter, sensitive, and motor. Look, this is an endorsal region, one AVM with hematoma. You go here, you go here, and you are embolized. This is another one. You go in here, and you embolize. See the glue. This is another one. It's very dangerous with hematoma. This is the vein. This is the nidus. I'm going with the catheter to the nidus. It's here. And inject the glue, and this is the control. This is the glue around the nidus. This is the glue. Totally occluded. Conclusion. It's important to know the architecture of the anatomy of the AVM and the possible way of collateral circulation. Replacing is fundamental. Is important your reflux and embolization with onyx don't use because it's very difficult to go far to the nidus. This is the reason why I utilize NCA diluted. And sometimes it's possible combination of the particle and NCA. Embolización with expert, I consider, in my opinion, the first therapeutic option in some case, but in other case, the first treatment is the surgery. I have more time, John.
Yes.
I have more time, 5 minutes.
Sure.
Okay. This is the Albuquerque hypothesis. This is paravertebral and spinal vascular malformation, cause of intramedullary venous hypertension or bleeding. The same as the dural fistula, but it's not the fistula. It's the paravertebral veins, drainer's vein. Albuquerque is a neurosurgeon from France. He's born in Argelia. He participated in the Operation Torque in Argelia. And he described the vein of the renal vein in the left part are anastomosis. This is the gonadal, this is the as anastomosis with the hemiaphibus. So you are here, hypertension, your stenosis here, the flow going to the cava, going here, and produce hypertension in the vein of the medulla. This is schematic. Left renal vein, aphibus here, and this is inversion flow, and you are paraplegic. Another schematic. This is the hypothesis. This is selective injection of the aphibus. You are the anastomosis of the paravertebral plexus, venous plexus. This case have multiple sclerosis. This is another theory. This is the plexus, venous plexus. So you are hypertension in this region. You are possibility to have a paraparesia. In 1976, described Albuquerque intraspinal hypertension due a telecabal system, a major cause of myelopathy. Increases the venous pressure in the side of the vein and explain some paraplegias and tetraplegias. So this is another article of Albuquerque and Lerich, the same, 76. The most important resume is the human study, 80%, 15% have a normal venous, 25 anormal venous, 1 abnormality venous, 2 abnormality venous, 3 abnormality. More abnormal venous have more possibility you are the deficit, motor deficit. In 80%, 60%, this is the conclusion. Some example. This is metameric venous, arteriovenous hypertrophy of the arteries, and venous drainage. Look this, you are hyperpressure in the vein, in the anterior spinal vein. I have conflict with the spinal artery. Lateral view. Another case, when you embolize, this is the MR, you embolize this bone malformation. You decrease the pressure here. Look, this is the vein. And the patient improve the symptom. And now the spinal artery with a second catheter going far. This is before going far. I improve the patient, the symptom. This is another, in another level, another patient. The same. Inject, close the communication of the bone. Look this with glue, and the patient improve. And finally, this is the final case is paravertebral and cutaneous venous hypertrophy. This patient has venous hypertrophy, or venous angiomas if you want, this skin, and perimedullary hypertrophy vein. And the patient have a paraplegia. This is the normal vein of the spinal, but possible. You are the conflict. This is the injection in the radicular vein by way of the renal, left renal. And you are here, the vein, and some connection. This is intracanal, intrarachidal vein. This is the catheter, this is the catheter, this is athigos. And you have 1, 2, or 3 communication. I decide to treat it by coil with 1, 2, 3 level to stop the flow, peripheral flow, athigos flow, to the canal. And the patient improve. This is very rare. The patient improve for this treatment. The same conclusion. The last is the same. The onyx. I don't like to use the onyx. I prefer to use MCS. Sometimes the particle is good. The anatomy is very important to treat this lesson. Thank you very much, John, and everybody.
Okay, Luis, excelente, gracias. Let me introduce the neurosurgical moderator, Harshad Parekh. He's a neurosurgeon from Mumbai, a frequent visitor to this group. Welcome, Harshad.
Hi, John.
Hello.
Hi. Hello, Professor Luis.
Hello.
Excellent presentation. Wonderful demonstration of the angioarchitecture of the spinal cord, cervical to the lumbar. Superbly demonstrated, both whether in a anatomical way and in radiological way. Superbly demonstrated. And you have shown all the kinds of examples of dural AV fistulas, AV malformations, intradural, extramedullary, and intramedullary. Wonderful, wonderful. And it is very highly technical job to do this kind of a embolization of the AV fistula, or even mostly more difficult is intramedullary AVM to embolize. That superbly done. First of all, I would like to ask you a couple of questions. One, when you are going through an arterial route, and suppose you are not able to negotiate your catheter right up to the nidus, what do? Do you leave the glue before the nidus, or you wait? Do you take any alternative route?
No, the glue is necessary going to the vein.
Yeah.
Because see, stop the glue in the pedicle, you have the collateral circulation.
Yeah.
This is the reason I use the glue diluted, because going some part to the vein. And sometimes you are many pedicles. When I learned with Professor Urt and with Las Junias in Bicêtre, I remember very well, Professor Urt put one clip in one pedicle, stop the surgery, and later 1 month or 1 week, put the second clip there to improve the patient. It's the same technique with the endovascular. The only difference is the glue or the embol going to the vein. But it's important to step by step, because you need the collateral circulation
To develop.
improve to regenerate the medulla.
How frequently, what is the time interval of multiple embolization if you want to do? How long you wait for one embolization and then second embolization? Suppose you have to do multiple.
About 1 month. About. It depends. But for me, the most important risk is in the dorsal region. The most easy is the cervical, because cervical you are many times two spinal arteries. And you have two spinal arteries, and it's possible to combine. But also when you embolize, the patient is by steroid. And see, you have free the complication with thrombosis of the vein, I recommend heparin anti-aggregation. Anti-aggregation minimal 1 week.
Okay.
Because the flow in the vein is very slow. It's possible progressive thrombosis. But this is the risk.
Okay. Do you have to go transvenous anytime?
No.
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 So
I treated one case in Colombia with transvenous, but the problem is the vein, when closed, the dura is not this.
Right.
You are a plexus.
Plexus.
It's impossible. You are a
Okay.
plexus. Every time you are a plexus. The only possibility is you open the dura,
Okay.
puncture the vein, and then inject. This is possible.
Even in AV fistula, I have seen one patient and I've done for somebody. Somebody was trying to do AV fistula and could not negotiate. And I opened it, and then we could put the catheter there, and then embolization was done. And yes, it does happen sometimes. But in a brain, yes, yeah, you can go navigate through the veins. In transvenous, you can do it. What are the clinical outcomes after, let's say, intramedullary lesion in the thoracic region who presented with hematomyelia, and you have done an embolization? And what is the clinical outcome? Do you also refer them for a surgical decompression, or it is just an embolization?
I don't know very well what is the risk to the hematomyelia when you close the vein. I remember very well the paper of the past century, Professor Alain Joannin in La Salpêtrière, remove the vein. This is the malformation. Remove all the vein and the patient is paraplegic. I think that it's not good. But some case it's possible. I think the collaboration with the neurosurgeon and endovascular is very important in some case. Now I start a new center with only neurosurgeon to treat it, not the venous, because I know the venous approach. I go more far. I go very function of the vein of malformation, brain of panel, by open surgery. This is my next step.
Right. Because these are very challenging,
and this is possible with Onyx.
Yeah.
Because I have experience in the dural fistula, brain fistula.
Yes.
I inject with the transosseous plexus. I inject with the papillon, inject contrast, inject Onyx, and push the Onyx to the communication of fistula. This I know. This is possible. I know I have experience for this. I think it's important to growth in this pathology.
It's very important to learn angioarchitecture. Very important to learn the angioarchitecture of the fistula or an AV malformation, and to understand from where it is feeding and where it is going, because the venous hypertension has to go down. Otherwise, the embolization is of no value. So it's very important. And angio-architecture, you have demonstrated very beautifully. Wonderful. Thank you very much.
And thank you for your question. And angio-architecture is my teacher last juniors, and the philosophy to treat it is Harness Niemi and Pertuset and many neurosurgeons expert in vascular malformation.
Right, right.
You know, the young doctor, like, wait, the experience. Sometimes it's better to study and wait.
Right, right.
Okay.
Very good. Excellent.
Well, Louis, I think we'll be able to follow along with you as you develop that here. So anyway, okay, we're going to move along, Louis. Thank you very much. And thank you, Harshad. And I'd like to introduce the next speaker.
Thank you.
Next speaker from China, from the China neurosurgical community, Dr. Xiaosen Zhang from Beijing Hospital in Beijing, China. He's going to talk about radiomics, machine learning, some basic mechanisms. So welcome, Doctor. It's all yours.
Thanks. I'm pleased to have the opportunity to present the conference today. Let me share my PowerPoint. Hey, I will share with you on the topic of some basic methods of radiomics and machine learning. Radiomics and machine learning have become significant research branches in the field of neurosurgery and have generated increasing attention in recent years. However, we must adhere to certain standardized methods to obtain sufficiently reliable experimental results for the further clinical interpretation. And I will introduce this topic through several aspects, included concepts, radiomics features, the pipeline of building progress, and the common machine learning methods, and at last, evaluation of the model. First, let's discuss the concept. What is radiomics? Here I introduce a website where you can find the documentation for the radiomics toolkit, the PyRadiomics. This documentation is essential for anyone conducting radiomics research, as it provides detailed introductions on how to use the toolkit. I want to emphasize 3 points here. First, radiomics is a set of biomarkers, and similarly to other omics research fields like metabolomics or proteomics. Second, radiomics features usually consist of 2-dimension or 3-dimension features, depending on the study subject and materials. For instance, when studying tumor MRI, 3-dimensional features are more appropriate, whereas the pathology slides, 2-dimensional features are typically used. Third, the radiomics research is a segment-based study where accurate segmentation is the first step and the most important step. Next, let's introduce several types of features. These are the 7 common types of radiomics features. The first order features, the shape features, the grid level matrix features, including 5 kinds of grid level matrix features. First, the first order features. The concept of the first order features is on the skin, and I want to say first order features primarily describe pixel intensities such as density values in the CT scans, including energy entropy, and density. And next is the shape features. This group of features will include descriptors of three-dimensional size or two-dimensional size and shapes of the region of interest. Shape features describe lesion morphology, supplementing in traditional measurements methods that one failed to accurately describe the irregular lesion. As we know, many lesions are not a regular lesion, such as a tumor or a AVM lesion. They are all irregularly lesions, so we need a more accurate way to describe the shapes of it, not only the diameters and also the volume, the surface area, the sphericity, the elongation and flatness, so on. And next is the gray level matrix features. Gray level matrix features, also as known as the high order features, are derived from the relationships between pixels of or voxels within the region of interests, such as the quantity of a specific class of pixels or the distance between pixels. These are crucial for determining. These are 5 kinds of grid level matrix features. They're all describing different relationship between the voxels. After that, the main purpose of introducing these features is to clarify that radiomics research is not an incomprehensible study. People unfamiliar with it may think that these features are purely mathematical and lack clinical significance, but in reality, all features can be described and can be correlate with clinical relevance, or at least serve stable biomarkers. And now let's discuss the basic workflow for building a machine learning model. Once we have a set of radiomics features, which can be very large, hundreds of features, even thousands of features, how can we effectively use these features to build a model to predict clinical outcomes? There is a standardized workflow which includes 6 steps, including data pre-processing, dataset splitting, feature engineering, model training and testing, the final performance evaluation, and the post-hoc analysis. The picture on the right of the screen is a standardized process of the study. For instance, in one of my studies, we performed a 3-dimensional significance of the lesions on the CT angiography images. As we see, we first collect the CT images and organize all the features into a data set through a accurate segment. This is a 3-dimensional segment. And then we collect thousands of radiomics features and combine with the traditional risk factors. All the features consist of the dataset of features. Once we have the features, the dataset was subjected to the dimensionality reduction, commonly like the picture in this part. Commonly using L1 regularization. Also, we may use L2 regularization, or principal component analysis can be also used. Next, we select a model architecture for basic construction, tested the model's performance, and finally extracted valuable features information from the model for analyze aligning with the research objects. The first critical step in the data processing is usually the pre-processing progress. which includes 5 aspects: the standardization, normalization, encoding categorical features, discretization, and imputation of the missing values. The discretization, this part of the pre-processing, I wanted to say more about it. Discretization is not a necessary step and can sometimes be counterproductive as it artificially introduces data cutoffs, which may create rather than respect the inherent data information. Furthermore, I think the discretization sometimes it is not to record the data, it is create the data. It is not such a critical way to do research. So I don't like this part of the pre-processing, and then I've never do that. Next, we need to do some feature filter. The feature filter part include 4 part of it, or 4 methods of it. First is the univariate feature selection. We need to perform some feature selection. A radio mix can produce thousands of features which may irrelevant to the outcome. These irrelevant features should be removed before model building. Commonly, the univariate feature selection is performed first to eliminate features without group difference. Although this method is usually reserved for the smaller focused set of the clinical features to avoid excluding important features through mathematical methods. For most features, L1 regularizations is a more common way to do that because of the large amount of the features cannot be compared through each group. It's not a common way to do that. And these regularization methods are basic machine learning methods themselves, including a lasso regression or a red regression, so on, and capable of parameters turning to obtain more reliable conclusions. Next, we can build a machine learning model. There are many methods, and well, I won't go into detail here, but based on my experience, 3 main considerations are: is the experimental design a classification or a regression problem? That is the most important problem to choose a basic machine learning method, because that present different outcomes of your research, or it may lead the research to a different direction. And then, should the model be linear or non-linear? Mostly, a machine learning research concludes thousands of features or hundreds of features, and so it is hard to make all the features in the same dimension to do the statistics. So mostly we use a non-linear model to do that. And the third problem is, does the model require strong interpretability, or is it enough to simply be efficient? And this part of the design needs to think about the design of your study, because some of the study, the target of the study is to build a strong model, enough strong model, but not to make the model to be interpretable. But mostly the study in clinical combined with machine learning, we need to make the model to be interpretable, because we need to know the features we collect or the features we choose. It is really mean in the clinical problem. Next is after the model construction, we need to do the cross-validation. As shown in this diagram, cross-validation splits the training data into several groups, each contain a validation set. We can see in the picture that the blue block is the validation data, and they're all in the training data set, and it is an internal validation method, usually displayed using a collaboration curves, just like this. The closer the curve, this is the curve. The closer the curve is to the diagonal, the better the internal validation is. And after the internal validation, we test the model on the test set. Results can be displayed on various ways, with common metrics being accuracy, recall, precision, and F1 score. The target of this part is to quantifying the quality of the predictions of the model. And more attractive, we can use ROC curves or confusion matrix for more vivid presentation. And finally, the model presentation typically use methods with both interpretability and visualization, such as nomograms, like this picture. The nomograms is usually used with the logistic regression. And the logistic regression is a simple or is an ordinary way to do some linear regression job. So it can visualize as a nomogram like this, and we can see the different blocks and the different scores present the different the difference between all the features. And this is a SHAP method, and it is popular in recent years. And these visuals are part of the post hoc analysis, highlighting the importance of various features within the model for clinical interpretation. As we can see, this is one of the research of mine, and we collect several different features from the model, and in this picture we can clearly see the volume of different features, which is more important to predict the outcomes of the research, and so on. That's concludes my presentation. Thank you.
Okay, thank you very much. Are you there, Harshad? Perhaps not. Okay. Anyways, I tell you, I'm not a neurosurgeon, but I'm not jealous. Now neurosurgeons in their training, they kind of have to know what's going on in the machine learning area and that part of the developing part of technology. Whereas other neurosurgeons didn't have to study that. Now it's almost a requirement, right? During residency, what do they encourage you to do webinars, or what do they do in the programs, in your program?
Thanks, Professor. In my opinion, the machine learning first is it's an important tool for the research of the popular neurosurgery, and we do our clinical jobs using the images, maybe CT images, maybe MR images. Those images can provide lots of informations for the research and make us to predict better the outcomes, such as I have done a research using the radiomics features to predict and bring AVM rupture. That is a important job for us, for all of my group, because we can use that to predict and rupture AVM, when will it rupture, or how high will it rupture, and that can help our patients to know if I need to do the surgery or not. And I think that the machine learning research it will be used more commonly in the future, because it is more interpretable and it is more critical, and we can get more information from the images we use.
It's more or less just starting the field, correct? As far as clinical application. Takashi, do you have any comments or?
Yeah. Thank you for the nice presentation. I'm Dr. Kon from Tokyo, Japan, a neurosurgeon. It's very difficult contents for me, so to difficult to understand. So it takes time to understand. But radiomics and the machine learning, so application of neurosurgery are very important. So how do you apply to a neurosurgical area? So surgery, tentative surgery. So this kind of machine learning is also important. So in a way, so the next step is to distribute your methods to neurosurgical field and contribute to the development of neurosurgery. Thank you for the nice presentation.
Thank you.
Are you giving a lot of presentations on machine learning now?
In China, yes.
Well, we would love to establish some kind of relationship with you if you want. Well, we'll chat about it later, but I don't think we can get enough, really. We basically promote videos in the neurosurgery field, similar to Medtion and brainmed.com, similar, but not nearly as advanced or nearly as don't have quite the history that those websites have. But I'm sure they're embracing developing the community of AI and machine learning. So I think everyone's interested in developing the community. But yeah, I'll be in touch with you. Just leave your email in the chat if you could, and I'll run some ideas by you.
Okay, thanks, Professor.
Okay, very good. Any more comments or questions before we close? Okay, very good. Okay, Dr. Zhang, I'm sure we'll be hearing from you in the future. And thank you for taking the time on a Sunday to teach us. Okay, everyone, we'll see you in 2 weeks.
2 weeks. Okay.
2 weeks. Okay.
2 weeks.
Bye-bye, everyone. Thank you very much.
Thank you. Bye.